So good morning. I'm Sara Edwards. I'm an orthopedic surgeon. I specialize in shoulder arthroplasty and sports medicine. And today we're going to do shoulder exam, which is my favorite exam. I think most of the time when you hear the history and then you do the physical, you can really isolate what is going on with the patient just by their exam. And I'm going to teach you guys how I do that. So first I'm going to start with just an overview of basic anatomy. So we're all on the same page, all right? So when we talk about shoulder, and they gave me a nice little model here. So, you know, there's three main bones that are involved here. You've got the clavicle, you have the humerus, which is our bone down here, and then the scapula. And the scapula is a really interesting bone. It's got all these processes where muscles originate or attach. So the scapula is where the rotator cuff muscles originate. They attach onto the humeral head. You've got the clavicle. So, and then there's two main joints too that we talk about in the shoulder. So when you say the shoulder joint, usually we're talking about the glenohumeral joint. And the glenoid is the process of the scapula that comes out and forms your actual joint. But again, the scapula is so big. You know, you've got the acromion process up top, you've got the scapular spine, and the coracoid process in front. So all these different bony landmarks can help you diagnose people, and they also, you know, they can lead you down the path of figuring out what the right pathology is. But we're all talking about the scapula, but there's different parts. So acromion, you'll hear me talk about, coracoid, and then the glenoid, which is the actual shoulder joint, the glenohumeral joint. But the other shoulder joint is the acromioclavicular joint, or the AC joint. So you can get pathology there, an AC joint separation or arthritis there, okay? So, that's the bony anatomy. And then beyond that, then you have ligaments. So you have the CC ligaments, so the coracoclavicular ligaments, or actually those are more over here. Then you have the AC ligaments, all right? Acromioclavicular, coracoclavicular are here, where the coracoid attaches to the clavicle. And then tendons, we have the bicep tendon. So you have two bicep, you know, bicep is two. So you have the long head of the bicep originates deep inside the joint. It's one of two tendons in the body that actually has an origination spot within the joint itself. So your bicep tendon comes off the superior labrum and travels down into the bicipital groove, down the front of your arm, and forms your muscle right here. Then you have the short head of the bicep comes off the coracoid process. All of our power usually comes from the short head. So you'll see patients with ruptured long heads and things like that, and it's not that big a deal, okay? That's why we're like, just leave it alone. Like, why aren't they fixing that? Because the long head, the power comes from the short head, not the long head. Let's see, and then your tendons, the big ones are obviously the rotator cuff, okay? So you have your rotator cuff anatomy, where there's four muscles that make up the rotator cuff. You have the subscapularis, which is the one in front. It's a long, flat muscle. I kind of like this model because it shows how long and flat it is. It goes all the way down the front. Most people just think of it as the tendinous portion up here, but it's actually kind of a broad, flat muscle. If you start looking at them on MRIs, you're like, oh, that's pretty big. It originates off the scapula, comes in to the lesser tuberosity of the humeral head. Then you have your rotator cuff muscles. So you've got your supraspinatus on top, infraspinatus is next, and then teres minor is in the back. And does anyone know which one ruptures the most? Supraspinatus. Okay, you guys got it. I know it's easy to lecture to a bunch of doctors, but it's more, I know, like you guys know. But yes, the supraspinatus, which is the one on top, is the most likely ruptured. And then when we're like, oh, that's a big tear, it's usually the supra and the infra. Subscap happens too, but it's less rare. Usually that's with trauma, like they've had a dislocation and the subscap can rupture all the way. Okay? So do we feel comfortable with our anatomy? Okay. So when I examine a shoulder patient, the other pathology that can mimic shoulder problems are cervical spine problems, all right? So I'm always concerned about their C-spine. Every single patient that comes in complaining of shoulder problems, I actually start with the neck because I want to know if there's a nerve impingement, if they have a nerve pinched at C5, 6, can radiate right down to the side of the arm and mimic a shoulder problem. So they won't feel neck pain necessarily, they'll feel it down here on the side of their arm. The other thing, before I demonstrate the exam, the history is so important. So what is the age of the patient? So younger people under 40, it's rare that they have a rotator cuff tear, all right? I don't think I understood that till I did a shoulder fellowship, right? Because I'd see people and I'd be like, oh, maybe it's the rotator cuff. But until, I didn't really understand this age differentiation until that's all I see. And then you realize, oh, rotator cuff tears don't really happen in young people unless there's some kind of trauma. You don't see those degenerative tears that are so common in people over 40, in the young population. Younger patients, you're thinking bicep pathology, labral pathology, the labrum, which is the lining of the joint inside. That's when you see in younger people, all right? Slap tears. Slap tear is a mnemonic for superior labrum, anterior to posterior. And then Bankart tears are when people dislocate their shoulder, which are generally younger people, athletes. Then you'll get an avulsion of their labrum off the front, okay? So those are the big ones I think about. As people get older, so you're looking at a 40-plus patient, that's where you start to see all the rotator cuff disease. So rotator cuff becomes much, much more common. You start to see frozen shoulder pop up, particularly in women, all right? The perimenopausal age, 40 to 60-year-old women have a high incidence. It's still relatively low, but when they're complaining of shoulder pain, you want to make sure they're not frozen. And then you also start to see your arthritis start to creep in. So people over the age of 40. All right. I will say rotator cuff disease is a spectrum. So it starts as inflammation or bursitis, and they can just have that. And then it can progress onto a partial tear, and then it can develop a full tear. So sometimes you'll say, oh, it's rotator cuff tendinitis, it's bursal inflammation. All those things are describing the same things. And you can't start to see those in young people, particularly people that are lifting a lot of weights, or you'll see that rotator cuff tendinitis in a young patient, but it's rare to see a full tear when they're young. I can think in 16 years of practice, I've operated on 2 patients under the age of 40 for a rotator cuff tear. I remember them because they're so rare. One was a girl who fell down a flight of stairs and she tore her rotator cuff. The other was a football player, defensive end, who dislocated his shoulder in a game, and he had a rotator cuff tear, but that's it, 2. So exam. So I always start with the neck, all right, because you want to make sure they don't have any cervical pathology. And I just generally say, do you have any neck pain? No. All right, and then I'll palpate right down the midline, okay? So I'll just gently take my fingers, palpate right down the midline, all right? And then I like to check, and then I'll have them do it. You can face the crowd. And then I'll have them do a range of motion. So can you extend your neck up like this? All right, put your neck down like this. All right, and then I'll have them, and then I do what's called a Sperling's maneuver. So Sperling's maneuver, and we'll stand to our side so they can see. All right, so I'll have them turn their head to the side, and you extend, and then I give an axial load on top. And if that reproduces their shoulder pain, then it's indicative that they might have cervical pathology. They might have either impingement or stenosis that's causing the pain in their shoulder. So, and we do both sides. So then rotate to the other side, extend, and you push straight down, and they'll say, oh yeah, that's what hurts. Yes?
So I feel like that a lot when people with shoulder pain, they'll complain of, pain in the trapezius or
yes.
the neck.
Great.
That's not a positive.
That's not a positive. And the reason that happens, okay, that's so common. They'll say, it really hurts here. My traps are so sore. And what happens, if your shoulder is not functioning correctly, whether you've lost motion, your rotator cuff's torn, you've got a shutdown of your rotator cuff, then you'll compensate by using your trapezius. So they'll get this overuse or work of the trapezius and get those spasms. I feel like I have them. If I'm sitting here, I'm like, oh, I know, I feel my trapezial spasm. But that's extremely common that they will say that. All right, very, very common. All right, does anyone have any questions about that? Yes?
Does it matter how far you're rotating?
No, just I usually 45 degrees or so and extend, okay? And the other trick, cervical pathology often will shoot all the way past the elbow. The other thing about shoulder pain, they'll say, oh doc, it's not my shoulder, it's just the side of my arm, it's right here. And you probably hear that a lot, it's down here. So when you have inflammation in the subacromial space, in the bursa, the nerve there is the axillary nerve that's right next to it. So they'll get a little radiation from their axillary nerve right in this subdeltoid bursal area. So that's not cervical pathology, all right? That is actually rotator cuff pain that they'll feel this kind of diffuse ache down the side of their arm. So that's very classic. They'll say, oh, it doesn't hurt up here, it's here. But that's coming from the shoulder, all right? That inflamed bursa irritates the axillary nerve distribution, and that the sensory portion of the axillary nerve is right here, okay? So that's what they feel. All right, so we've checked her neck. Her neck feels great. She's fine. All right, so then I'll move on and I'll start palpating. Well, first I'll visually inspect them. All right, so I like the patient. If it's a female, I put them in a gown so I can actually see. Male patients usually are comfortable taking their shirts off and I can look. Or if women have a sports bra on, great. But you want to look at symmetry. You want to look at atrophy of the muscles. It's astounding what you can see. Sometimes you'll just see this complete atrophy of the muscle. You know, and then you think, oh, there's a neurologic problem. Something's going on with their nerve, maybe cervical pathology. But I'll look and I'll see if they're even. If there's trauma, you'll see bruising, swelling. You can see displacement. If there's a clavicle fracture, you know, you'll see a noticeable drop in the shoulder. AC joint injuries, if it's bad, you'll see, you know, we call it ptosis of the shoulder, like ptosis of the eye, but the shoulder will have ptosis as well, where it drops down. So I'm looking for that when I look at her, and she looks great. So she's symmetric and even. And then I'll start palpating. And I start at the sternoclavicular joint, all right? And then I'll palpate along there, all the way out through the clavicle to the AC joint, and you can feel it, all right? And I'll document sternoclavicular joint, no pain. AC joint, no pain. Or they have pain, they'll tell you. Sternoclavicular injuries are extremely rare. So it's rare to see that. AC joint injuries are pretty common. So you'll see if they have arthritis in the AC joint, they'll say, oh yeah, that hurts. If they've had trauma and they've fallen on it with cycling, I see that with football, you know, any kind of contact sport where they're falling on their side. It's very common to get an AC joint sprain or injury. And so you'll palpate and they'll jump. They'll say, oh yeah, that's it. That's what happened. It's right there. And then I'll palpate the bicep tendon. So the bicep tendon is right in the front, and you can kind of cup your hand around their deltoid muscle. This is your deltoid, and you can roll your finger, and you'll feel it. You feel that? Yeah. So, and you can feel it on yourself, you know. But you'll feel this like cord-like structure roll under your thumb. That's your bicep tendon. So if that is sore or irritated, that's a sign of bicep pathology, tendonitis, partial tear, maybe a full tear. All right. And then you can also palpate the greater tuberosity over here. Pain at the greater tuberosity is a sign, and that's, you'll feel their acromion process, which is the bony part on top. And you go right down the side. If that's sore there, it's a sign of a rotator cuff problem. Or a fracture, if they've fallen, okay? So that's what I palpate, all right? Then I have them go through a range of motion. So I'll have them put their arms in front, and then I'll check all their ranges of motion. So we'll do forward flexion, all the way up, all right, perfect, all right, and bring it down, and then let's stand to the side so they can see, yep. And then I do abduction at the side, and I write all these on my exam. So forward flexion is 180, okay, it's full. Abduction, 180 degrees, full, okay? And I do external rotation at the side, so do that, and that's usually, hers is around 70 degrees, okay, 70 to 80, you can estimate, it's fine, but you're really looking for symmetry, you know, so she's even on both sides. If you see, now I'm not symmetric right now. I dislocated my shoulder a few months ago. And you can see I'm like 45 degrees and I should be at 70. So I'm not quite healed yet. I should probably go to PT. I'm too busy to go to PT. But I'm like, I'm cheating. But yeah, I've got an interesting body. So anyway, that's your external rotation at the side. Okay. And then internal rotation, you can check behind the back. Okay. And then we document it, you know, we'd say, oh, she's at the T4 level. And patients that are older, have arthritis, you'll see, like, they can't get there. They'll be like, oh, I can barely do this. They'll be right at their buttock or at their lumbar spine if there's a problem. And again, I'm always looking for symmetry, all right? Now, what if her motion is off? So what if you're examining someone and you see a huge discrepancy? Like, okay, I'm up here, and this one I can only get to here. And then you have to do a little more work. All right, so you document, okay, that's active motion where the patient is doing it themselves. And then that will stimulate, if I see it's grossly different, then I will check passive range of motion. And that's I will have the patient lie on a table to check their passive range of motion. Does anyone know why? It's a trick question, kind of. Say that? Yeah, well, gravity is one reason. But, okay, so the shoulder joint, there's 3 joints really. So I said there's the AC joint, the glenohumeral joint. There's also the scapulothoracic joint. So where the scapula moves along the rib cage is a joint. Yeah, and you get motion from that, all right? So 2/3 of your motion, or I'm sorry, 2/3 come from the glenohumeral joint, 1/3 comes from the scapulothoracic joint. So people can cheat a lot using they'll wing their scapula up or move it more. And that's why that trapezius gets sore if there's a problem, because they're using the trapezius to lift the shoulder using the scapula. So if you have them lie down flat, supine on a table, you're isolating the scapulothoracic joint. It won't move, okay? So, or I should say you're isolating the glenohumeral joint. Then you can just test the glenohumeral joint. So I'll have them let's have you lie down here. Let's see. Is this safe to lie on? Okay, like it's safe. We don't want any ortho injuries here. Okay, so I'll have her, assume she's off and different, and then I will take them through a range of motion. So I'll check, okay, your forward flexion is great, your abduction is great, and then external rotation, she's very flexible. Internal rotation, you can do at the side like that, okay? And those are the 4 things I document. But you want to check, is active equal to passive? Now with a rotator cuff disease, which is the most common shoulder pathology we see, the active and passive motion should be full. And patients will limit, they'll say, oh, I can't lift because it hurts to lift, but can you move it? Yes, okay? So that's how, and they won't like you very much if you do this, but you know, I always tell them, I'm not trying to hurt you, I'm just trying to see where it will go, but I'll take them through a range of motion, and if it's full, that doesn't preclude rotator cuff disease. Rotator cuff disease, they should be equal and full in both upright and lying down. The ones that will be, it'll be locked, it'll physically be blocked, and you'll try to lift them and they'll stop right here. There's only 3 diagnoses that happens, all right? One is, does anyone know? I'll ask the question. Why would you, which one? Frozen shoulder. Okay, that's number 1, frozen shoulder. Which one? Arthritis, yeah, so if the joint is arthritic and kind of blocked down, the osteophytes will actually block you from getting full range of motion. Which one? No, muscle tear, it will move the whole way. It will move the whole way. It will move the whole way.
Dislocation.
Dislocation, all right, she's on it. Okay, yeah, so if it's dislocated, and sometimes, you know, most of the time a dislocation, you can sit up, most of the time a dislocation would show up in the ER, right? Or urgent care, they're not gonna come into your office. But sometimes I'll see it, particularly like elderly women or men that have been in nursing homes, skilled nursing, and if they can't move their arm, like sometimes they've been lifted in a really inappropriate way and their shoulder will have dislocated and they'll have a chronic dislocation and it won't move. So I probably see one of those every 6 months. So it's not terribly uncommon. Family will be concerned, they'll have, you know, the primary care will be concerned, you know, why isn't she moving her arm? They come in and I physically can't move it and it's out, it's dislocated. So you can see these chronic dislocations. The acute dislocations, usually they're screaming in the ER, so I don't see too many when they're acute. So any questions on that, on range of motion testing? Because that to me tells me a lot right there. So if they're blocked, I'm like, okay, it's one of these 3 things. And the x-ray then will tell me. Okay, I'll get the x-ray, I can see all those, they always want an MRI because their shoulder's not moving, and I'm like, well, you've got a frozen shoulder, you've got shoulder arthritis, I can see it, or you've got a dislocation and we have to operate on you. So, okay. So then we do strength testing, all right? Yes?
Are there any particular views for the shoulder x-ray that are important to
Yeah, I do 3 views, okay, and usually like a true AP, where you're at the 30-degree plane. I do an axillary lateral. So the only true way to see a dislocation is on an axillary lateral view, where they shoot through the armpit and you can see if the humeral head is located on the glenoid, okay? That's important. And then I do an outlet view, and that shows me the morphology of the acromion, okay? A scapular Y or outlet, either one, but they're a little bit different angle. But I prefer the Y to show me the acromion morphology, okay? But so yeah, if you're gonna order shoulder x-rays on your patients, true AP, outlet, axillary lateral. Because if you just write 3 views, they'll do like 3 APs. Okay. That's always frustrating for us. So we're like, oh, there's a bunch of APs, that's great. Or they just rotate the patient like 5 degrees, you know. Or they have them go external and internal, but it doesn't really show us all the things. What I'm looking for is like, is it located? What's that axillary lateral? It's really important. Okay?
So besides this location, what are you looking for? Arthritis?
Arthritis, yeah, absolutely. I look at the shape of the acromion to see, you know, is it flat? Is it curved? Is it hooked? Because I look for an osocromial, an unfused piece of bone that's present in 5% of people. So those are the main things. I'm looking for trauma, if they've had a traumatic fall. Looking at the AC joint, I'm looking at the greater tuberosity to see if it fractured. So those are the main things I'm looking for in X-ray.
How common is other pathologies like tumors, osteonecrosis?
I see them. I mean, I see one a week. I catch a tumor once a week, which is sad. So that's where, you know, they always joke, you know, you go to the orthopedic office, you're going to get an X-ray, and that's why, because we see these things. That's why, you know, even after a period of time, sometimes you don't see them, and then you'll get an MRI a few months later, and there it is, there's the tumor. I caught one the other day. I caught a tumor in a young guy, a 38-year-old. It was in his coracoid process, and I'm looking at it, and I'm like, I see, it was a lytic lesion in his coracoid, and sure, I got the MRI, and yes, it's a met. He's being worked up right now, but you know, once in a, you see him. It's always a sad day for, you know, we do all these sports things, but we do catch the cancer sometimes. Yes?
The numbers that you're looking for are like lytic lesions for soft tissue, other tumors or even, I guess you can see them.
Yeah, I mean, the soft tissue things usually would turn up on an MRI, but yes, in the bone itself on the X-ray, you get mets from whatever cancer, you know, breast, lung, thyroid cancer, all those metastasize, renal cell, they metastasize to the bones most frequently. There's one of the breast, lung, thyroid, renal, prostate, yeah. And some are blastic, where they form bone, and some are lytic, where they dissolve the bone. So that's part of our residency. We get that drilled into us to be able to see them. And again, when you're looking, I see 40 patients in a day, and I look at X-rays all day, and then after a while, you just can see, like, oh, there's something weird on that X-ray, you know. It's interesting. So let's see. Oh, muscle testing. Okay, so then we want to test, if you want to test strength, there's a lot of special tests for the shoulder, and this is where it gets fun. This is where you can really tell where things are. So face me. So normally, you know, she has good strength. We would test all dermatomes, so I'd have her test, you know, or right here, let's go, this C5. You know, she's got good strength, muscle like that, C5, 6, and push against me, and then extend. So I'd test their bicep, their tricep, she's trying to push away, wrist extension, okay, hold it there, wrist flexion, hold it down, and then the interossei muscles right here, so have her hold it out. So I run through that on every patient. And then, but there's specific ones for the rotator cuff muscles. The main testing we do are the Neer, the Hawkins, and the Job test. These are your rotator cuff tests. The Neer test is someone will have pain, or the Neer sign, when they're forward flexing between 20 and 120 degrees of flexion. So if you lift your arm up, and the patients will say, okay, it doesn't hurt, then it starts hurting, and it will hurt, and then it will go away as they get higher. All right, and sometimes you can lift it for them. So sometimes, you know, I will do this for them if they really don't have the muscle strength to lift, but you're checking for an issue there. So that's the Neer test. When I'm testing for strength, so there's this test, so it's got many names, upside down can sign, so put your thumbs upside down, or the Job test, named after Dr. Job in LA at the Curlin Job Clinic. But you test here, so this is isolating your supraspinatus. This is very sensitive for supra. And if they have a tear, they won't be able to hold it. So this is how I determine who I'm getting an MRI on their first visit. If someone's got good strength in this test and all the rotator cuff test, I say, oh, you can probably do PT, and then we'll see you back in like 8 to 12 weeks. But that's how I determine, based on these strength testing. If they're weak and they can't hold it up, and I'm concerned about a rotator cuff full tear, then I'll send them for the MRI, okay? So, you know, so this test, the Job, all right? And their arms are, abducted about 30 degrees with thumbs completely, down. And then for the infraspinatus, you go down here, so external, push external, and then you have them resist you right here. You try to push in and have them hold out. And that isolates your infraspinatus. The only muscle that does that is infra. Yes?
It could be intermittently positive, sometimes they don't.
It is hard. They will sometimes be limited secondary to pain. So the muscle will be intact, but they won't hold it because it hurts. And they'll drop their arm, and that's always hard to find out. That's why sometimes I'll order the MRI just to see, if they're torn or not. You can give them an injection, lidocaine, or lidocaine with steroid, and see. And if they can hold it then oh, the muscle's intact, they're just inflamed. So, yes?
Sorry, for the infraspinatus, is she?
She's holding it out. Yeah, so she's externally rotated at the side, and you push in. I'm trying to push her in to make it collapse, and she's holding. If their infraspinatus is torn, they'll go like that. It'll fall in. If they have a massive infratear, if the whole thing is off, they can't even go there. You'll put it out here, and their arm will drop in like this. And that's called the external rotation lag sign. So that's an infra tear. The teres minor tears, which are rare, it usually doesn't extend all the way back to the teres minor. You put the arm up here and here, and then I'll have her resist and hold it. That's called the horn blower sign, like you're blowing a horn on a train or a truck. But so horn blower's test is normal on her, but if it's positive, they'll droop down. They can't even hold it here. So this position is held by your teres minor. Okay? And then subscap, there's a few good tests. The subscap is the lift-off test. So you put your arms behind your back, and then you lift off. So push out. That's your subscap muscle doing that. And I'll push. Can you hold it? And they'll hold it. But if they can't do that, it's a sign their subscap's torn. The other one that's good is for subscap is the bear hug. So you'll have them do this, like they're hugging themselves, giving themselves a big hug. So just do one. Let's try this. And then you can pull against it. And that also tests your subscap. So those are kind of the big ones for strength, all right? So supra, like this, okay? Infra, teres, okay? Subscap, behind your back. Yes, oh, and the Hawkins test, I didn't show you. Okay, thank you. All right, so face me. So the Hawkins test is another rotator cuff sign. So, and again, think of rotator cuff disease as a spectrum. So Hawkins could be positive for impingement, inflammation, bursitis, partial tearing, full tearing. Any of those could be positive with the Hawkins test, okay? So Hawkins, it comes here. So you're forward flexed 90 degrees, you're internally rotated, and we rotate down. So you support their elbow, and then you push them down, and that will make your shoulder impinge and cause pain if they have rotator cuff problems, okay? So this one, Neer, Hawkins, and Jobe. For a superior labral tear, a slap tear, the best test, face me, is called the O'Brien's active compression test. And it's similar to the Jobe test, okay? The upside down can, except their arm comes in a little bit. So you're about 10 degrees adducted, but same motion, you're all the way down, and you push, and they'll say, oh yeah, that hurts, okay? Now a positive test is if you rotate them where the thumb's up, you push again, and they go, oh, there's no pain that way, okay? So pain here that's alleviated when they rotate up. That's the best one for a slap tear. And I'll have you lie down one more time. Yeah, and then for instability, for gross anterior posterior instability. So they call it the load and shift test, but we put the arm, so if I put the arm in this position, is this more vulnerable for an anterior dislocation or a posterior dislocation? This is anterior, right? When you're in this position, externally rotated, abducted. So if you think about sports that this is going to happen, basketball, right? They put their arms up. What football position do you guys think? I'm always thinking like a sports wide receivers, right? They're going to catch the ball. Okay, reaching up, boom, they can pop out if they get tackled. Anyone getting tackled in that position It's going to, anterior dislocations are what you think about. So we put them in this position. Sometimes this alone is enough to bother them. It's called anterior apprehension. So just being in this position, they'll go, oh, no, and they won't let me even touch them. That means their shoulder is subluxing anteriorly in that position and they're uncomfortable. I will push down on them, give them a posterior force directly on the shoulder, and they'll say, oh yeah, that feels a lot better. And that's a positive relocation test. Again, showing they have some anterior instability, they're subluxing out the front. You push on them and they go back into place, okay? And then to load and shift, I'll take my hand like a little C, wrap around her proximal humerus, and then you load it. You give an axial load at the elbow, and then you can push, you kind of give an anterior directed force. And then you can also check posterior the same way. You give a posterior directed force, and that's called a load and shift. She's very stable, so I'm not feeling any movement. But that's how you test. And if you have to be careful because you can actually dislocate someone on the table. So if someone's told me they just had a dislocation, hey, I was in the ER last week, I dislocated my shoulder, and I don't make them do that because I'm scared I'm going to pop them out. All right. Now posterior instability. So come towards me. So I'll have them kind of off the table a little bit, and then we go in. This is the vulnerable position for posterior instability. This is when people will dislocate out the back. And this is not super common. The ratio of anterior to posterior instability, 95% of dislocations will be anterior, 5% are posterior. Posterior, do you guys know what they're associated with usually? Trauma, seizures, or electrocution. So they get this very fast force that will drive their arm back from the muscle contractions. So sometimes I'll see one, like I'll have someone who's using drugs and they'll have seizures, and then they'll come in with posterior dislocations. But to test for posterior instability, you give a posterior directive force right on her elbow, pushing down, and they'll go, yeah. Now the athletes I see with that, what sport do you think I would see that most in? Well, I'll give that away, it's football. But all instability is most common with football. But what position? What'd you say? Alignment. The linemen get it, because they're blocking. So they're running up to each other. You guys, did you play football? You look like a football player, strong. But they're blocking, and then they get that posterior shock all the time. So I do see it in football a lot, actually, with the linemen. Okay? So that's shoulder exam. Do you guys want to practice? You want to take some turns?